government project officers. As a reminder, we are only the group that is providing technical assistance. And as I mentioned in our last webinar, we are not the ones that will be addressing rules and regulations and policies and funding awards and announcements and things of that nature. We are here just to provide technical assistance. So the last major goal for this funding is reducing the unmet treatment need and opioid overdose-related deaths through the provision of prevention, treatment, and/or recovery activities for opioid use disorder. I want to say real quickly that as you develop your strategic plans, particularly those of you who are developing them from scratch, know that these goals are what is governing this funding. In other words, you might have a much more ambitious set of goals and objectives because you might be funded from multiple sources. We just need to be very clear that the activities that you put on your strategic plan, your goals in some ways have already been sort of defined for you here on this slide, and we reference you back to the application itself to look them over. And obviously you can add additional goals, but you need to make sure that these are the major ones addressed by the associated objectives and activities that you will develop. Next. Harold?
Thanks, Pam. Yeah, and so just to emphasize that point, so when you look back at those two goals, even when you get to your performance measures or the outcomes that's based on, you'll link back to that. So essentially that is helping SAMHSA to achieve its logic model, and then whatever you're doing in your activities and your measurements are really targeting, to demonstrate the contribution you're making to increasing access and reducing unmet need and overdose-related deaths. In terms of this slide here, I support Pam's comment. There was a small sample of the narrative sections of the application that tribes had submitted, and we did take a look through those. I want to emphasize the point of please send us more narratives. That will put us in a better position to help. But in terms of the ones we looked at, here are 4 types of approaches that the tribes are indicating that they're taking for to do their quote-unquote comprehensive strategic planning. So there are some who are actually going to do a comprehensive strategic plan and have hired a consultant to go through that process, and there's real value in that. Others are using other distinct planning methods that aren't strategic planning specifically, but they name a few specific ones that are out there, and those provide a different kind of a framework and are designed to develop different tools. Again, to help the tribe do more coordinate, be more holistic, be more social determinants approach. One of the emphasis that they make there is the whole point that the planning process and the activities that you go through are just as important as the resulting plan that comes out of it. And I just want to emphasize that, and that's a critical piece you'll see in a couple of slides here, but just working through the stages of a strategic plan, engaging in the discussions that are necessary, reviewing and analyzing the materials that you'll pull out, that helps people who come at strategic planning from all different levels, and we're fairly confident, out there you have some pretty sophisticated strategic planning experience. But it does help to sort of winnow through, so it helps to demystify strategigic planning. It helps to unravel the complexity which you may feel now as you look at the FOA, you look at your application, you look at all the other work that you and your organization are doing, you look at the complexity of this particular addiction. So it helps to unravel that. Once you can do that, you can sort of see your way to better alignment and coordination. And then once you see that, it helps you to then sharpen your strategy and sharpen your focus. And to be quite honest, that doesn't all happen in the first round. Sometimes that takes, various cycles of strategic planning for that to take effect. Sorry, I just got an echo feedback there that threw me off. So complete a comprehensive strategic plan, use distinct other planning methods. Third one, link to existing tribal action plans. So there are some other plans which are often related to substance abuse or opioid specific. And then they're using that to sort of then focus on the next activity. And in this particular case, we looked at, they're going to focus on developing their needs assessment over a longer term period. And then the fourth approach being taken is to link to other ongoing strategic planning processes that may be going on within the organization or are funded through other mechanisms. And so again, those are different ways to do that. Yeah, so that's really all I wanted to say on that piece, just to give you a sense of the variety of approved approaches which are available to you. And the fact, and we'll come to the strategic planning template we put together, which SAMHSA has sort of said, this will help you get to the bulk of it. In some respects, I think the requirement on strategic planning is driven by the Government Performance and Reporting Act, or GPRA, which, is heavily laden with strategic planning. And so you could see where that language had to start. But I think as they're getting into shorter term, 2-year projects, I think they're recognizing they've got to find a middle ground between strategic planning and action planning. Next. And Kay, just repeat those numbers again, if you don't mind. Is that easy to do?
Yeah, so for the first question, there were 14 people who said that yes, they do have a strategic plan that they can use to work from, and 11 people said no. And for the needs assessment, there were 10 who said that they have done a needs assessment, and 11 who said that they did not.
Okay. All right, so we're split pretty evenly, and again, we're trying to do this in a way that supports that. What this slide is showing you is essentially what are the 7 or 8 steps of a strategic planning process, and we're going to focus on number 1. Yeah, and as we go through, what we're going to try to do is give you definitions and templates and some techniques and help you with the analysis, on each of those stages. So as you're doing your own version of it, you'll have some technical context to build off of. Let's go to the next slide. So here's just a little bit more detail in terms of what we talk about, what we mean when we talk about getting ready. So essentially making sure the program, the department, the organization is ready and able to commit the time to do the strategic planning and look at the big picture. One of the things we often use in discussing this is when we're looking at the issues that we need to identify, focus on, what are those things? What are the big questions we need to ask ourselves? Where are the tension points? What are the issues we've got to discuss? What I've listed here is a couple of ways of looking at them. So, of course, in the FOA, it talks about prevention, treatment, recovery, aftercare. So those could be 3 easy bundles to use in terms of identifying the questions that you need to discuss. The next set is a list, and I see I've listed financial stewardship twice. There's actually a reason for that, but in a lot of strategic plans, these are the areas which you'll wind up looking at. You'll look at financial stewardship is usually the lead issue when you're talking from a corporate business side. So that's kind of why I put it first. I meant to move it. Community engagement, sort of constituency needs from a not-for-profit and particularly from a tribal side, that, and again, a health program side, that really is the motivating function there. And so often that has a higher priority. Then it's, financial stewardship, it's our internal processes, and it's our organizational capacity, our learning and development that needs to happen. So those are all some types of issues you could be thinking about in terms of what are those handful of issues that need to be examined. Those will then get winnowed down. In some models, they actually try to winnow it down to 3, but 5 to 7 is a good working amount. When you're looking at those issues, there is a technique around, is it a strategic issue? Is it an operational issue? Is it a crisis issue? And strategic just means it's a bit more future oriented. It's a bit more long-term, at least longer than a year. Operational is much shorter, day-to-day, more activity-based, so to speak. And then crisis issues are, of course, the crisis of the day that we're often dealing with, and in this field, it could be that, there's many health crises that we have. So that's another way of sort of analyzing the issues to try to boil it down to strategic issues, those that ask you to sort of lift your head up and look down the road a little bit. And then really the next piece is then defining the planning process that you're going to use. So in the previous slide, we kind of laid out some of the steps. And essentially, you're going to ask yourselves, who's going to do what in that process? Is it all your limited number of staff? Are there other consultants? Are there other experts in your organization? Are there other people that you're going to involve? Is it community? Is it leadership? Like all of these kinds of pieces. And you do need some leadership commitment on this. Whether you want to create a planning committee, whether within the organization or broader is another question. Again, the hiring of a consultant, it could be, that's very dependent, I think, on the scope of your budget. So that's another issue. I see somebody's having a scratchy throat there. I just want to urge you to speak, mute your mic there when you can. Whether there'll be a form of a retreat, often in strategic planning, everybody rushes to the retreat, but essentially it needs to be designed, and you need to do this sort of initial analysis to help you make sure that it's the most productive as can be, as possible. I'm a big fan of the retreats. I just think they need to be very well designed. And you can include your internal and external stakeholders, so to speak. And I know stakeholders is a tough word to use in a tribal environment, but just thinking of those people who would have an interest in it. And it could be, nothing prevents you from engaging your funders or your health and treatment partners or your prevention partners in your strategic planning process. As you'll note there, just getting their input helps you to shape your approach. Getting their buy-in helps with the implementation of your strategies. And then the last piece in getting ready is really the big piece we're going to focus on here is what information do you need to gather to help you make decisions, right? So you're going to pick some issues, you're going to make some choices. What's the information that's going to help you analyze that number or that issue? In strategic planning, often one of the hardest parts is actually finding the strategic plan or being clear which strategic plan is enforced. So sometimes we have multiple versions floating around. I've actually done a project where there was a legendary strategic plan and strategic planning event from 12 or 14 years ago now. And I've been working with them for 2 years. We've rewritten their strategic plan because given that 12-year gap between them, it really needed a new one. But I have yet to see that original plan. So information gathering can be a little bit harder than we think. The next slide is an assessment checklist. And essentially this one shows you some basic content of a strategic plan. And the content depends on the model you choose and the process you lay out. Here's some of the basic things you'll do. And it just helps you to sort of then say, do I have it? Does it work for me? Is it aligned with the work I'm going to do on the opioid strategy? What kind of revision? Does it need revision, first of all? And then what kind do I need? And then the assessment comments, just to help you get a better feel. When you look at all of that, it helps give you a better feel for the scope of work that could be involved in creating your strategic plan. So again, those dozen or so items on the left are some of the basic elements you'll often see in a strategic plan. And then in terms of this, when you look at the priorities and the goals and the objectives, that's the kind of stuff we've tried to incorporate into the template. We'll talk about it in a little while. And just for reference on the objectives, I stands for immediate, S stands for short term, M stands for medium, and L stands for long term. So depending on what your frame is, if it's 2 years, the math is pretty clear. It's 5 years, the math is pretty clear. Sometimes strategic plan can be 10 and 20 years as well. It just depends. That's not necessarily the context of your grant approval at this point. The next slide. What I've done is I pulled out some definitional stuff. I often make the advice, don't quibble about definitions, just try to make sure that it makes some sense to you. But here, I just wanted to make a distinction between a strategic plan and a strategic planning process and a strategy. They go hand in hand, but they have certainly different things. You can use a strategy kind of anywhere, anytime. And a strategic plan is a way of sort of organizing those strategies with a longer term focus that gets you to a certain result. And then strategic management is just how you then organize and how you coordinate that from a management function and just tries to lay that out. And the reason I mentioned this one is because when we take a look for some existing opioid strategies, we don't see many opioid strategic plans. We do see strategies, and have which have a variety of different approaches that people are taking. We don't see a lot of vision and mission statements. So again, that's another reason why we want to be just conscientious of the need to adapt strategic management, strategic planning to the work that you're doing. And just remember that really the strategic planning process and the strategic plan itself is just a tool to help you make choices and to make sharper strategy decisions as you're going, planning to go ahead, and as you're, even when you're trying to make choices midstream, your strategic plan should help to inform those choices. The last slide I'll talk to, I think, here is the lessons learned about planning and assessment. So essentially, when you look at all of these tools, this one was focusing primarily on organizational capacity, but these are some of the lessons learned, and we kind of mentioned a few of them. They do provide a good framework for having the conversation, unraveling the complexity, aligning and coordinating, sharpening your strategy. Participation in the process is often as important, and for some people more important than the tool itself and the result that comes from it, the product that comes from it. Making sure the tool fits your context, so your level of experience, the number of staff, your budget, the cultural context that you're in, the scope of the project that you're focused on. Adapting tools, getting familiar with them and adapting them to your needs is, essential. This point here on often these tools sort of do these surveys or these polls, or they have a lot of checklists that you can use. And what I'm just trying to summarize here is that when you use yes/no scales, they help you to understand best practices and where the gaps are. When you're looking at those new number ratings, scales, Likert scales, I guess, scales of 1 to 5, they really help to understand excellence, areas of excellence and improvement, and then the rubric or the wording. So you choose from a descriptive statement. So they just help, again, to have a better conversation. I'll give you an example on that. So on mission statements, a rubric or a wording one would be, one, we have no written mission statement, and it's very verbal, and it's only held by a few. 2, we have some expression within the organization's purpose, but it lacks clarity. And 3, there's a clear expression that respects our values and our purpose as an organization, and it is held by many. So that's another rating scale you can use in these tools to then help you make some judgment about how much or if any realignment is necessary. Facilitation criticals, and what we've seen in some of the applications and the narratives is that some are bringing in consultants, some are not, some are doing it internally, and really it can be in whole or in part, just bringing in the expertise when you need it. And then the last point we often see is both the funder and the organizations can benefit in sort of the how-to training about the tool itself. So again, in a quick nutshell, that's highlights on strategic planning. We just wanted to reference the template itself, maybe before we turn to questions. Pam, do you want to do that?
Sure. So we created, and we'll show you in just a minute, a sample planning template that you might want to consider or might want to adapt. And that is, again, for those tribes who don't already have a preferred strategic planning format. What the plan template will ask of you is to clearly define and state the problem that your strategic plan will solve, identify the activities that will be completed to solve this problem. So, for example, some of you, particularly those that received a much smaller amounts of money, may have narrowed your population of focus to, let's say, youth or to women or to some subset as opposed to all tribal members, while others might have, been looking at any tribal member with an opioid use disorder. So being very clear as to what the problem is that you're trying to address with your strategic plan, and then how you will attempt to get there. And part of those decisions about how you will get there will be informed by lots of different kinds of data, including epidemiological data, and we'll give you some examples soon. Also considering your tribal capacity, strengths, and challenges when you're developing your plan. We have examples of some tribes that have been, for example, implementing medication-assisted treatment using all 3 FDA-approved medications, and then there are tribes that might only be using one, and there are tribes that have never been providing medication-assisted treatment. And so really, you're all at a different phase of your capacity building, and so you'll want to factor that in to your efforts. Also, embedding tribal traditions and values into your planning activities is very important, and also developing objectives that are measurable, define accountability, who is going to be responsible for this, when will it be accomplished, and resources and timelines. Next. So the example of the strategic planning template, right after, go to the next one, please. Okay, so this is the example of the strategic planning template that we created as just one sample. We have this on your TOR website. That is part of the ATTC. We'll give you the web link again before we end today. But you can see that we started with objectives because the goals are pretty clear. They've been established by SAMHSA. You may want to add additional goals, but this is an example. You would put your objective in, and then how will you, what steps will you take, what activities will be undertaken in order to accomplish the objective. Then, for example, who is going to be responsible primarily for carrying that out? What is your target date? And then did that get accomplished or not? And so if we can go, what I want to show you is some examples that you might fill in this particular template. And again, you're free to adapt it, adjust it, or use something completely different. If you go to the next slide, please. Next slide. Okay. So I mentioned at the outset that there were three different types of activities. There is the required strategic planning activity, which is what we're doing now today. And then there were other requirements, and we covered these in our orientation a couple weeks ago, but I want to cover a few of them here now in relation to what you would address in your strategic plan. And by the way, the template we showed you a minute ago, this is more of sort of a rapid strategic planning process, not a true long-term involved strategic planning process. And the reason that we created this is that you've had 60 days from the date of funding award to turn this in. And so in talking with the project officer that we work with and technical assistants and some work that he did with other SAMHSA folks, determined that, we'll at least give you something that if you don't already have a strategic plan, give you something that you can get underway with, get something out there that you can begin working towards, knowing that it will be a work in progress and that you will continue to develop it and improve upon it and expand on it over time. Now, what some of these other requirements are in this first one, I cannot emphasize enough how wise of a decision it was for SAMHSA to put this in here. It is another requirement for all of you to implement workforce development activities to ensure that individuals working in tribal communities are well-versed in strategies to prevent and treat opioid misuse. This workforce development activity is absolutely critical and should be one of the objectives that you would fill in on your template that we just showed you or in your other strategic planning documents. Just to give you an example, I've spent the last year and a half working in this exact initiative, but with states, the state opioid response grants or the state, opioid targeted response. And one of the things that we have learned the hard way in working in states is how much bad information people have or misinformation about opioid use disorders. So for example, for the first year that we did this work, we were hearing back from the community partners, from criminal justice, child welfare, all the groups that you might have to work with in your delivery of opioid use disorder prevention, treatment, and recovery. We were hearing things back like, we don't believe in putting people on, medication-assisted treatment because that's replacing one drug with another. And so we had to go in and help people understand through workforce development and training that no, putting someone on a medication, one of the FDA-approved medications, if properly dosed, helps remove some of their cravings, helps stabilize their brain functioning and helps them become able to function while also getting concurrent therapy and other traditional practices that makes them able to function and to be successful. And if they're parents, to safely parent. So there was a lot of bad information that we had to overcome through training. There were judges who, for example, were not allowing children to be returned when they were taken through foster care, not allowing them to be returned to parents who were safely stabilized on medication-assisted treatment and in recovery programs because they were under the impression that these parents could no longer effectively parent their children. A lot of bad information. There's a lot of stigma out there. And so realizing that you're all at different phases of development and you all have different budgets, and so some are more ambitious than others, just understanding that you should have some type of objective that deals with this key workforce development activity. Also making sure that the work that's being done is culturally responsive. And so one of what we're saying here is that it makes sense for these other requirements that you see on this slide to become objectives, because if you're required to do these anyway as part of the SAMHSA grant, then you might as well get credit for them, might as well convert them to objectives that you then will develop activities around to move forward. Another example, develop effective prevention strategies, which include but are not limited to, and this is right out of the RFA, or excuse me, out of the FOA, the Funding Opportunity Announcement. So examples like elder education, outreach and engagement of youth, strategic messaging, community prevention activities, and also developing strategies to purchase and disseminate naloxone, that's the overdose reversal medication, and provide training on its use to first responders and other tribal members. So this is important here because this is SAMHSA recognizing that opioid prevention is almost on its own spectrum, where if you know, when you look up, and I mentioned this on the orientation, if you look up or Google opioid prevention, 90% of what you find will be preventing overdose. Well, those of us who've been doing this a long time, and SAMHSA being a prime example, recognizes that that's pretty far down the road. Overdose, reversing an overdose is pretty far past what we would consider, other primary prevention activities for opioid use disorder. So it's important to work with the youth to get ahead of this problem before they get so far downstream that they're overdosing and dying in our tribal communities. So, this strategic messaging, getting the community involved. So however you decide to tackle this, again, working in concert with your project officer to then figure out what kinds of prevention strategies do you want to put on your strategic plan so that you are effectively meeting this second requirement. And then the next one, and this is so long that we really couldn't deal with it on this slide, but we're referring you to page, I'm sorry, if you can go back real quick. If you go back, we're referring you to page 7 and 8 of the funding opportunity announcement, that you have to implement service delivery models that enable the full spectrum of treatment and recovery support services to facilitate positive treatment outcomes and long-term recovery. Some of these you will be doing directly. Some of these you might be partnering with other entities that are already doing some of this work. But if you go to page 7 and 8 of your FOA, you can read about various examples, and they give you a link about where you can learn of some more effective service delivery models, since that's one of your requirements. Next. A few other examples: incorporating culturally appropriate and traditional practices into your program design, supporting innovative telehealth strategies in rural underserved areas, and using technology if you have access, addressing barriers to receiving medication-assisted treatment by reducing the cost, or developing innovative systems of care to expand access to treatment to support long-term recovery. So all of these are located and can be described in your grant funding opportunity announcement. And then developing and implementing tobacco cessation programs, activities, and or strategies. I want to clarify here that this slide that we're looking at right now is what would be the end of the required activities, again, working with your project officer to figure this out, how you will go about this, unless you've already been clearly identified this in your application. Next. Then we move to the allowable activities. And so again, some of you that got more robust funding based on the size of your tribe may also want to engage in these other optional activities, such as implementing community recovery support services like peer supports, recovery coaches, recovery housing. There is a caveat that if you do decide to move into the recovery housing area of opioid work that is supported with these grant funds, that it has to be an appropriate and a legitimate facility, and that individuals in recovery should have a meaningful role in developing the service array used in your program. So these, again, are optional, provide assistance to patients with treatment costs, and develop other strategies to eliminate or reduce treatment costs for under or uninsured patients, provide treatment transition and coverage for patients reentering the communities from criminal justice settings or other rehabilitative settings, and working with tribal epidemiology centers to assess the impact of the grant. So these are allowable, optional activities, not required. But those of you who have suggested these or put these in your application that you submitted to SAMHSA would need to make sure that you then address these in your strategic planning template. Next. So this was, do we have a polling question, or are we just asking folks if they want to submit additional questions?
Additional questions.
Kate. Okay. So feel free to put any additional questions in your chat box, and Kate will review them and read them out loud, and we will answer them at this time. And this is questions that cover any of what we have covered thus far in this presentation. And then after this, we'll start moving into the data collection.
There is a question in the chat box from regarding the role of the tribal epidemiology centers. Is there an evaluation role? And if so, what is the funding consideration, please?
So I would refer you back to your project officer for that, the answer to that question, because we do not address funding awards.
And there's also a comment there about a group that's actually in its strategic planning process right now and wondering whether they should stay connected to this or go back to their strategic planning process.
I can answer that very quickly. If you've got somebody there helping you with strategic planning, I would say absolutely go back to that, because we are, this is being recorded. And so you will be able to play this entire webinar back, after this is over, and sync up what we are covering with what you're already doing. But it's very hard to pull people together and to be respectful of the time that they've committed to do the strategic planning. And given that this is recorded, I would say, please, it will not hurt our feelings if you hang up and continue with your folks.
As valuable as we think
okay.
Where we're trying to be.
Yeah. All right. Is that it for questions now?
Well, there's another question.
Oh, go ahead, Harold.
Yeah, so Pam, just in your chat function there, do we only have to address the objectives from our application, or must we address each required activity on page 7 and 8 of the FOA?
Well, theoretically, probably both, but I would refer you back to your project officer, because the application, the funding opportunity announcement was very robust and covered a lot of information and a lot of requirements. And some of the grantees that got much smaller amounts of funding may find it difficult to do that, but they are directed to go back to their project officer to sort of work out that. Keep in mind also that that it may be that some of these are addressed in year 1 and some are addressed in year 2. In other words, perhaps there's other ways to sequence these various activities to make it make sense both for your funding amount and the scope of work that you have proposed. And we are recognizing, and we did this in the orientation, that this was a very rapid process. We did get a lot of feedback from tribes that said, we had, I don't know, I think it was 10 days or something to pull this together. And it was, everything was moving very quickly. And so then it was, congratulations, you have an award. And now, all those things that you put in there have to be done. And the realization of rubber hitting the road about how do you do that and still adhere to what you said you would do. So that is something you'll work out with your project officer. And I figured out, Carol, thank you, my looking at the chat. Yeah, and as somebody was mentioning that that their funding is so small related to the requirements that they're very committed to responding to this problem, but they are quite aware that they have a very limited amount of funds to do this. Also, this is a good opportunity to see, are there other people, there's a lot of opioid use funding out now. Funding that went to states, funding that went to tribes, funding that went to communities, funding through the criminal justice system, I think even now soon through housing. And so it might be a situation in which you partner with other folks within your community to figure out what are you signing on to do and how can you help leverage the things that are already happening and build on some of those. So that might help. Okay, next slide. Okay, so this next section on data collection, what we're going to do here is to very briefly show you just a few examples of very helpful opioid use data that is readily available on, using the internet to download. And then Harold will talk a little more about how do you supplement that data or those data in, with other processes. So next. Next slide. Okay, so the examples of the kinds of opioid relevant data that you might want to consider looking at, and again, this is for folks that haven't already done this or don't have a good handle on this. There are incidence and prevalence data. Just a quick reminder that prevalence is the proportion of the population that has a particular disease or disorder at a point in time. So that would be, what proportion of your tribal population already has an opioid use disorder. If you were to freeze time and look at what is happening, that would be considered prevalent. And then incidence is the rate of the new occurrences of this disorder. So that this is where you would, you pick up, for example, that incidence conveys information about the risk of contracting this disorder, whereas prevalence is how widespread it is. So again, prevalence is point in time, incidence is the new cases coming in. And so that's where we've heard from many tribes that they are concerned about opioid use disorder, but they have a huge problem with methamphetamine. Well, you might have, this is an instance where the prevalence of opioid use disorder might be low in your area right now. But if you start looking at the incidence, the number of new cases coming in with opioid use disorder, you might be shocked to see how quickly that is percolating along. And so again, wanting to get ahead of this, and SAMHSA was very comprehensive in their prevention, treatment, and recovery. And those are critical, like a three-legged stool. That any one of those legs missing could make the stool fall down. So it's critical to have all of this. And so incidence and prevalence is very important. I'll give you some examples in a minute. Then overdose, fatal and non-fatal. A lot of times people forget when they look at overdose, or they might look at mortality data. So people who have passed away from their opioid overdose and start, going down that path, forgetting that mortality data is everybody who died, and many people, thanks now to the overdose reversal medications, Narcan and other versions, that were able to bring people back to life or prevent their death. And so there's a whole host of strategies that should be happening with those individuals. You know, examples, I think I covered a few last time, like, you know, are we making sure that we have plenty of overdose reversal medications for first responders, but also for individuals who are opioid use disorders, so they have it on them, on their person. If they're likely to overdose, somebody could grab it and administer it, and also family members and friends. And so, you know, looking at even anyone who has overdosed, we know that there's a high likelihood of more than one overdose, that a person might then go have a second or third overdose. So looking at how do we target those individuals to make sure they have access to a medication. So you want to distinguish the fatal and non-fatal. Also, I think I mentioned last time that there's some very interesting programming going on where coroners are sending letters to the prescribers of opioid medications to let the doctors know, hey, you know, 3 of your patients this month that you're giving pain medications to have now died of overdoses. And we're seeing in those studies a reduction in heavy prescribing. So perhaps it's having some influence on how much of a medication and what the dosage is for people who are on legitimate pain meds so that they don't accidentally or intentionally overdose. So that's an example of a strategy that would distinguish fatal and non-fatal. Also, tribal epidemiology centers. I'm going to come back with some examples here in a minute. We didn't cover IHS data because it's our understanding that that is one group of data that most tribes already are accessing and able to use. Then we have other SAMHSA and Centers for Disease Control, CDC data that we'll cover. And then things like, you know, how many people are receiving medication-assisted treatment using one of the FDA-approved medications in your tribe, and are there any waiting lists so that you know, are there certain areas, you know, that would be important to offer medication-assisted treatment? Are people having to drive, you know, long distances to access this kind of care? You know, are there ways of using telehealth and behavioral health technology that might expedite some of that? And then there's lots of other examples that we're just giving you a few here. Okay, next slide. So first we'll go to the SAMHSA, next slide. Okay, this is an example of incidence and prevalence data, and I'll give you the link to this. This will only help you identify the incidence and prevalence of substance use, including opioid use, by state. It will not go down to the tribal level, but it might at least help you start to, you know, get focused in on what is happening, at least in your geographic area. And the data is quite current, and it is also based on the National Household Survey. And so the other really cool thing, so if you go to the next slide, you'll see the link to the data. And you don't have to type this up because, again, you'll have the copy of this slide presentation so that you can access it, I think, even by way of a hot link. And then if you go to the next slide, you'll see that SAMHSA really is trying to help folks by supplementing the data, the national household data, with very specific opioid tables, opioid data tables. And so what's happening is, well, first of all, I don't know what it is in tribes, but in states, most of the physicians treating this population will say that about 90% of individuals who use opioids are using other substances. That's another piece for another day. You know, in terms of the education that we need to do about this. But SAMHSA recognizes that while the household survey will give you lots of general data about substance use, that you might want to drill down to some more specific data around opioid use. So there, and the link to these data is to the left of the slide. And so they'll show differences, for example, in heroin use versus prescription pain reliever use, because, you know, you might be focused more on heroin than prescription. Maybe your tribe is going to address all opioid use. So, but if you're looking for a particular type of opioid use, these tables will provide you that level of information. Also by demographics, they'll give you, who by demographics, race, and ethnicity are using which kinds of opioid substances, and also by gender, and also looking at some trend data. So I really suggest that if you have an opportunity, you look through some of these slides. If you can turn to the next one, please. Once you have access to these links, if you haven't already gone through this process. We recognize many of you have already done this. So here is just a general map of opioid overdose death rates. Again, not overdose, but overdose death rates. So you always have to pay attention when you're looking at data as to what it is you're actually looking at. And this is per 100,000 population. So you can see here that the lighter the color of the state, the less problem of opioid overdose deaths is at least being documented. And then the darker the color of the state, the more severe. And you can see the little key at the bottom of the map. And so you might pick out, what state is your tribe located in to see, what kind of data, what is the data suggesting to you about how important of a strategy this might be for whatever funds you have to work with. Next. And this is when you see the link to these data, you will see that in this slide, you can drill down. So when you hover over the state, you can drill down and pick your state out. And, hopefully you can see a little bit here. I'll just cover, and you can see it's really interesting how different these the use is and the overdose is by state. So we have two A states, Alabama and Alaska here, and you can see that the overdose death rate is 7.5 per 100,000 in Alabama, but 12.5, not quite twice as much, but a good bit more in Alaska. And then they also look at, that's for opioids. Then the next column is all drug overdose, recognizing you can overdose from other drugs, not just opioids. And then, is there an increase? What's the percentage change? Is our trend line going up or down? So these are the kinds of, you're just going to need to spend time, if you haven't already done this, to really look at these data and get a sense of what does the data suggest you should be doing if you haven't already undertaken this step. Again, normally, if you know that this funding opportunity is coming, you have plenty of time to do this, but you might have 60 days to write the grant application, and you're doing this all during that time. We recognize the time frame did not align that way, so some of you are, I guess you'd say, changing the tires on your car while it's driving down the street. You're trying to get this all pulled together while doing your strategic plan and getting ready to have your services up in January 1st. Okay, next. Okay, that's the link that would take you to the data from the past two slides that I just showed you. Again, you'll have access to this upon when the webinar is over. Next. So these are tribal epidemiology centers, also called TECs, and this website, haven't already gone here, this might help. I know we had a question about this earlier, and I just did a screenshot of what you'll see when you go to the website, and what you can do. And of course, the link for that website is to the left. If you go to the next slide, you'll see a map of where these different tribal epidemiology centers are located. Oh, it might be the one after this. Sorry, there's another view of the website, and there's blogs that are interesting that show you what some of the discussions are. Sorry, you've gone a little bit too far. I'm looking for the one with it. There it is. Oh, back. There you go. So if you look at that map, what you'll do when you go to this website is, again, hover over where your tribe is located, and to then contact, if you're interested, that the tribal epidemiology center that's associated with your tribe, and find out what kind of data they have that you might use for your strategic planning. And if you'll see to the right, they have a lot of other really cool resources, best practices, documents, and so forth. So if you're not familiar with this, I highly encourage you to spend a few minutes over the next few days seeing what is available. On the next slide, you'll see just a couple examples that came from that resource of the Tribal Epidemiology Center. Very, very alarming, looking at the overdose deaths. Now, this is not by tribe, but this is looking at Native Americans in the United States over this 16-year period, and you can see a very concerning upward trajectory, so that we see that these overdose deaths are on the rise. And so what you'll want to do is see, while this covers all of the U.S., can you have access to these kinds of data just specific to your tribe? Or how close can the epidemiologists associated with your tribal center get? You know, what kind of information can they get you to help plan? And next, there's another slide next that it also came. So this is interesting because whereas the first slide showed you the overdoses in general, what we want to do when we're trying to determine what our priority is for services is figure out, well, who is most affected by this overdose, So you can see here that really from age 25 to age 64 among Native Americans, that is a huge, there's not a lot of difference there, 15.3, 15.2, 14.7. So you're seeing a large percentage of overdoses in the 25 to 64 year range. So if we want to get ahead of that, obviously you're looking at Narcan and other overdose reversal strategies for those, the age group of 25 to 64. But what you want to do with your prevention is see that you're going to have to do something different in the 15 to 24 age range. You're still wanting to prevent overdose with Narcan and other strategies, but in patient education and lots of other strategies. But that you might want to look at some of that work with outreach in your community and working with youth in schools and tribal elders and so forth. Next. Oh, and the male-female was the other thing. You want to look at male-female differentials. Okay, so here's another resource. This one, just to give you the link there as well, this describes what the tribal epidemiology centers are, how they are working with CDC, but only in 3 of the tribal epidemiology centers. So this might not be helpful to everyone, but I would encourage you to take a peek at it and see if it happens to cover your specific tribal epidemiology center. Next. Next slide. And then this is also very interesting, a map of the United States showing where the prescribing rates are. And so you can see that by the color of the little markers there in the various states and within the regions of the state, that there's very uneven prescribing. So, assuming that everyone has similar rates of opioid use disorder, and I'm not sure if this is age adjusted. So for example, if you were in a state that had a large number of retirees that are getting older and having aches and pains and having cancer and things, and so they might have more prescription opioids than others, or if you had military bases where there's folks that are, coming back from serving that have injuries that might be more likely to be overdosed, adjusting for those kinds of things, you would think that other than that, the prescribing rates should be fairly similar. And this shows you, and again, you can get the link and find out more about it, that there are some areas that are much heavier prescribing areas than others. And so why is that? Is that a case of needing more education to the prescribers about, is it really necessary? I might have shared, I came back with a 30-day supply of opioids from getting a tooth pulled. I didn't ask for them. My husband filled the prescription because I was out of it and I didn't know that was even being done. And I ended up using a single Tylenol. I didn't need 30 days. I didn't even use one of them. And so then I had to go through after paying for them, take them and discard them so that somebody, one of my 21-year-old daughter and her friends didn't accidentally get a hold of it in the medicine cabinet. So anyway, those are things. This is a link here that will show you that overdose map. Okay, and also provides other opioid data that you might want to look at. Next. This is another, SAMHSA has a link called Bisque. It's a data center, and what it does is it provides all kinds of reports that are very helpful around various topics. And this one covers substance use and mental health issues among U.S.-born American Indians or Alaska Natives residing on and off tribal lands. It is fairly new, in July of 2018. I believe when I looked at it, the data was from 2014. But again, these are documents that we found for you that we feel might help inform some of your process. Next. These are some other data sources. We won't go into these, but just a few examples of places that you might look at for data. Next. Okay, so the good news is there's a lot of data out there and a lot of other sources of information. The bad news is that there are some limitations. And so much of the data is state level, not tribal. So that means you'll have to find other ways to drill down if you don't have access to good tribal data through IHS or through the tribal epidemiology centers. And I can't emphasize this next point enough. The data may tell you that something happened or did not happen, but not why. So for example, let's say you do all of this due diligence and you look at all your data and you find out that there is a huge surge in opioid use, incidents, a growing new cases of opioid users happening in middle school in your community, at that age group of young people. Well, it tells you that that happened, but it doesn't tell you why. So you're not sure, well, what do I need to do about it? Why is this happening in this one community? Or why did I see a doubling of overdose rates in people that are leaving in incarceration? Why is that happening? Well, when you then have to go the next step to ask a lot of questions, and Harold will talk a little bit about this, so I won't spend any time on this, but just remember that data will tell you something happened, but not why. Not all data is opioid specific, so some of these data sources might also include other drugs. That may not be a problem since these are often used together. Also, one of the things that, again, you should include in your educational campaigns is that a lot of folks believe that if they take a pill that looks like a legitimate pill from a pharmacy, let's say, OxyContin, and they have a pill and it looks just like it. Maybe they didn't get it from their physician, but they got it from the street. That is most likely a counterfeit pill, a counterfeit opioid pill that was created in China or Mexico or in somebody's pill press in their garage, in which case we have no idea what's in it, none. We don't know whether it's got fentanyl, which could kill them very quickly. We don't know if it has just, some other kind of toxic poisons. We don't know what is in there. So data might be labeled as opioid, but it might not tell you it was fentanyl or it was a legitimate opioid or it was something, manufactured in someone's backyard. So again, you really have to work with your key informants, people that know maybe in law enforcement or in other sectors or treatment centers about what's out there and what's really happening. The NSDA data, the National Survey of Drug Use and Health that I mentioned that SAMHSA has access on their website, does not always cover people that are homeless. You have to have a home or a phone for to take the survey. I know there is some sampling of other populations, I think incarcerated populations, but we all know that there's a number of people that are affected by opioid use disorder who are not factored into the data that we look at. So we just need to remember that it may not include everyone. Opioid users typically use multiple other substances. Data sets use varying definitions, complicating your ability to aggregate the data over and across sources. For example, we might collect data from 12 to 17 and then 18 to 24, but someone else might collect it from 12 to 15 and 16 to 30, and so or even what they count as an opioid. So there could be lots of differences in definitions that make it hard to roll this data up. Opioid mentions within morbidity and mortality is often underreported due to the complexity of multiple drugs present. So that means that you may not, if there's a lot of drugs present in someone's system, it might have been the opioid that killed them, but that might not be what's listed on their death certificate. So it's often undercounting opioid deaths. Also things like, let's say somebody overdoses in, let's say in a tribal community, but is transported 20 miles away to an emergency room, and the death occurs at the hospital, maybe that death is then counted in a different zip code. So it's underreporting what's really happening in your community. So I'm going to turn it over to Harold now to talk a little bit about the importance of gathering other information to support the data that we've just walked you through. Harold? And next slide.
Thank you very much for that. I was just unmuting, so. Yeah, so just as we move to the next slide, what I really wanted to emphasize is there's lots of data points in your applications. So, these are the questions we're asking you to think about, in terms of the way you phrase the issue and the approach that you're going to take. In this conversation, we've really tried to talk about what's the, how do you develop your process so that your planning, your strategic planning, your analysis then kind of helps that. And then we've thought, in terms of getting ready, it's about pulling together the available data. And, these were some, sources. The challenge, and I think Pam's noted that, is that we have access to a lot of general data, very difficult to get tribal specific or tribal opioid specific data. From a planning and analysis point of view, really what you're trying to do is use the best available data and information, and then look to see what are its implications for how it informs your planning, your strategy, how you're going to achieve the things you've laid out in your application and in your funded proposal. Information gathering often comes with the challenge of, how representative is it? And especially when we're working in the communities, trying to find that representative sample can be a bit challenging. And so there are other techniques we can use. And I just wanted to talk about focus groups, for example. We have a tendency in the tribal community to do community meetings and public meetings and sort of general meetings that anybody can come up to. But really trying to, if you use the focus group methodology, you can at least have an approach that targets certain sectors of your population, engages them in a productive conversation, and then through the methodology get you to get input that can be quantifiable. So think of it as a social marketing focus group. There's ways to do that. So for example, it's still inclusive in the sense you can do focus groups with youth, you can do focus groups with elders, you can focus groups with young parents, you can do focus groups with your professional staff, you can do focus groups with your, prevention, treatment, recovery partners, internal and external. So there's a number of ways of doing that. In a focus group, you can also do a lot of surveys and worksheets and various products or models that you can then use that allow you to get more quantitative data from what is often, like from a public meeting, it's often just sort of anecdotal data. So it's a way to quantify the information that you're receiving. The other thing I wanted to just mention about community meetings is there is a way to sort of improve the productivity of those meetings. I did a consultation and engagement session on nuclear power and waste in 2 First Nations communities. And essentially we did focus groups, and the focus groups where we had the original tough conversations, as you can imagine, in that particular topic. And then when we came to the sort of broader community engagement, we actually structured it a little bit differently, used a bit more facilitation techniques, including training community members as facilitators, so they were facilitating the conversation as opposed to myself or others who were sort of outside experts. Regardless of how well we might have been known in that community, we were outsiders. We also used a bit of a different process to bring the people into the conversation, in the sense that we started with ceremony. We then moved to an open house where there was a lot of one-on-one conversations, a lot of information desks, a lot of places to get to have a conversation and pull information from the community from. And particularly given the sensitivity of this particular one, that can be very useful that way. Then we had the meal, which is often our strategy that the community is pretty tuned into in terms of getting them to come and attend. But we also, after the meal, and during the meal, there were conversations going on. And then after the meal, we had what we called the conversation space. And so that was the community meeting, but designed differently so that it wasn't people coming into a head table in chairs in a theater style and sort of that dynamic. We did it circle seating, no real head table, community facilitators using norms about how to ask the tough question, how to have the sensitive conversations and, you know, still be respectful, sort of how to fulfill our traditional values, so to speak. And then just by using those sort of modified techniques, more culturally appropriate approaches and sort of throughout the day, ironically, after the meeting in each of the communities, the chiefs took me aside and said, that was the best community meeting we ever had. And, you know, I kind of was very happy about that, given the topic that we were talking about. So just in terms of information gathering, just wanted to sort of lay those out. Focus groups as a way of getting, you know, both qualitative and quantitative data and input, and then community meetings done differently so that you can in fact have a different conversation than what often happens when we sort of gather before with our projects to do these briefings or get these inputs from the community, or, you know, have our regular community tribal meetings. Pam, I don't know if you wanted to do much more on information and other.
No, I think that was it. Just a reminder that, you know, going back to look at your application to remember, did you identify a population of focus by gender, age, or geographic location or tribal affiliation? What did you say you would do? You know, what data or information do you already have? And what data or information do you still need to effectively implement what you promised you would do in your application? So, you know, we realize that we've covered a lot of information in this first webinar, and we'll cover in a minute the ones that are coming up. But that this is sort of a crosswalk between any existing strategic plans you might have, looking at developing new ones if you don't, giving you an option for sort of this sort of rapid strategic plan using the template that we provided, or one adapted that makes sense for your tribe, and then working closely with your project officer. Also, we'll be sending something out about this soon, that, and we mentioned this in our orientation meeting, that we will be having a grantee technical assistance conference or event meeting in Mystic Lake, Minnesota, sometime, I believe, the first 2 weeks in April. I don't know if we've gotten the contract worked out yet in a firm date, but what we recognize that you will have to have your services up and running by the 4th month of this grant award, which makes it in January. And since our TA meeting won't be until April, what we want to do is make sure that we provide you with whatever technical assistance you feel you need to be as ready for that important start to service implementation as possible. So if you need training on different medications for medication-assisted treatment, or how to meld medication-assisted treatment with traditional practices or different prevention opportunities, or whatever it is that you're finding the need for assistance on, especially as you start putting these things in your strategic plan with dates and times, and, you know, you're signing up to do these things. We are here to help you in any way that we can. And if we can't do it within our own group, we'll reach out to others who have that. We also know that many of you on this call, and particularly the larger orientation call, have a lot to teach us and to teach each other. And so we want to be very peer-to-peer focused as well. And if we can go to the next slide, not only, oh, sorry, go ahead. Yeah.
I just wanted to add one thing. So just thinking about this, there is a tool that I use, and one of the strategic planning models is the Grove Facilitation Graphic or Visioning it's called. They have an agenda setting template there, and I'll post that I'll send it over to the Technical Center to post on the website. It's just a creative way of looking at it, and I would just say focus on start planning. If you're going to do that, information gathering through focus groups or other kinds of meetings with your constituency, look at this and sort of helps to design that meeting to be more effective. And in fact, what it also reminds me of is just to ask the participants if there are suggestions you could share with us about how we can improve these webinars themselves. We're very happy to see those as messages in the chat room. Okay, thanks, Pam.
Excellent. Sure. And so now we're opening it up for questions again by way of chat before we close out today's webinar.
Yeah, and Pam, you have Megan's question. Are we able to reach out to you for guidance in addition to our TA officer?
Guidance around technical assistance, absolutely. That is what our contract is here to do. And so we're going to give you the link to our resource page, and you are welcome to reach out to us. We also have, while we have 6 webinars already scheduled on strategic planning, we have reserved 2 that we have not yet formatted. And so if there are specific topics around strategic planning or even other topics that you would like to recommend that you need assistance on, we're happy to do that as well. I believe we do have some funding that would enable some individual work by phone and also potentially some in person, but most of the work we'll be doing will be done either in regions where we bring grantees together and or through our meeting coming up in April.
Yeah, and just on that, Pam, I wanted to note Daniel Harland had offered to share. He's finished his strategic plan and he modified the template that was provided to do that. And he says that once it's finalized and approved, he'll share that. And so that might be something we can do as one of our latter webinars and as a part of one of our latter.
Oh, that's fabulous. Yes, and thank you so much, Daniel. And we appreciate that. Anything that can make it easier for others, so that we can get this important work done. Let's see. I don't see anything else. And I know we're getting close to our time. Okay. So, Kate, should we go to the next slide for the upcoming webinars and our closing slides? Or yeah.
And Kate, is there a way, if any of the participants want to send in a bit of an email later or a note in terms of how we can sort of do continuous improvement on the effectiveness of these webinars? Is there a way they can do that?
Yes, I will chat my email, and I would be happy to have people contact me, and then if there are questions that might be best directed elsewhere, I can pass those on, but I'm happy to field those. So thank you for mentioning that, and I will add my email to the chat box here now.
Yeah, and I just want to say to the participants, as a former tribal chairman, I have a thick skin, so always looking for help.
Yeah, me too. After 40 years, it'd be hard to offend me at this point. So please, we are here to serve you and to provide you the technical assistance and training support you need to do the very important work that you have in front of you. So these are the upcoming dates of our next strategic planning webinars. One again tomorrow, that is assuring alignment with vision, mission, values in your submitted TOR application. Then on Friday, the environmental scan, SWOT analysis, capacity considerations, and priority setting. The one on the 16th of November will be around developing objectives and strategies. So, how do you create objectives and strategies, and what's the difference? And we'll provide some samples and such. And then the last two, bringing it all together on the 19th and the 28th. And I think, Harold, you were suggesting that that would be a good time for us to showcase someone like Daniel's work or others that we might have, and also maybe even the tribal action plan, and that shows very well worded objectives and strategies and things of that nature. So we'll try to be very practical on the 19th and the 28th with examples. Next. So closing suggestions. You've got a lot of work ahead of you, and I know you're doing a lot of simultaneous work getting these things going. But we encourage you to work closely with your project officer to get some of these questions answered. I know we're getting a lot of requests asking who the project officers are or how to contact them. And I know that they have, a lot of people they're getting in contact with. So if it hasn't happened completely by now, I believe it will be very soon. And we will look very much to your suggestions that you have for us to keep this moving forward. Next.
Yeah, and it just, I noticed some attrition as we went through the day. Some of it was the group that was doing their strategic planning, but perhaps in terms of the communications to the TORs, we can also reach out to them outside of this webinar in the chat room.
Excellent. So you'll see that we have created a tribal opioid response resource page, and that is, some of you have already been there. The link to that is, I believe that's a hot link that will work directly to, but I'm going to ask Kate if you can clarify how they would get to the resource page.
Yeah, so I'll share the link in the chat here, but it is right on our ATTC website, which is attcnetwork.org/native. And I'll type that in here, but then there is a menu on the left-hand side, and as you scroll down the menu, towards the bottom is the Tribal Opioid Response resource page, or it's truncated to TOR resource page, and you'll see we will be putting all of the webinars there, so there will be direct links to the webinars there as we get those all lined up, as well as the resources that were mentioned previously.
And Kate, if I have a lot of resources that I've found to create that data collection section, if I send you those PDFs, is that something you can put so that it saves everybody the hassle of trying to link and find it and download it, if they can just go right there and get it?
Absolutely.
If I send those to you, could those be put there? Okay.
Yes, I can do that.
Great. Okay.
All right. And Pam,
and we'd encourage each other to, go ahead, Harold.
I was going to say there's been a request for us to provide our information, so perhaps we can do it here in the chat, but maybe Kate, just under our introduction slide there, you want to add our emails, or at least mine. I don't know, Pam, if you're good with that.
Sure. Yeah. And I think we could just say it now. Mine is P as for Pam, P Baston, BASTON @jbsinternational.com. So P Baston, BASTON @jbsinternational.com. And Harold, could you state yours?
Yeah, mine's harold@tarbell.ca, and I put it in the chat room.
Wonderful.
Okay.
Great.
And then
yes,
go ahead.
Oh, sorry. I was going to say I will add that to the handouts when we prep the PowerPoint slides to send to everyone.
Okay, great. And then if you see the last bullet on the TOR resource page, we are still looking for grant applications. That's how we are going to know how best to help you, and how best some tribal grantees can help each other, so that we'll be able to know, oh, another tribe had that same situation come up, and here they addressed it very effectively. Why don't we link you to them? So we have a very involved process where we're able to connect, create sort of an at a glance or an overview of who's implementing what, where, and for what populations. And it's sort of an analysis that we do that could be very helpful for all of you. But in order to do that, we need your applications. And so we've created a special website at JBS International, tor.ta @jbsinternational.com. And again, my address is the same as you see there, except it would be pbaston@jbsinternational.com. And if you couldn't remember that, you can probably reach me by just sending a note to the tor.ta. Next, I think last maybe. I think we made a mistake here on this slide. It said we'll soon announce a dedicated webpage. We did actually get the webpage established, and that is the one that Kate is sharing with you. And so we're so appreciative of the time that you're taking. We know you have a lot in front of you in a very abbreviated time frame, and we thank you so much for joining us and appreciate any feedback, as Harold said, about how we can improve these webinars and also how we can be of greater assistance to you. And Harold, do you want to sign off as well?
Yeah, the last thing I want to say, I just want to acknowledge that the note asking for examples as soon as possible, just given the short time frame. So that's something we'll have a good conversation about on our side. But thanks, everybody. And there is, I think, one more slide.
Oh, okay. Oh, that's right. Next. And this is Jeff's, you talked to him, I think, very briefly in the very beginning, who is heading up this initiative. And his contact information is there. I think you saw his photo in the very beginning. And so I know he would welcome any suggestions that you have or any questions that you might have as well. Okay. Well, thanks, everybody. And we look forward to speaking with some of you tomorrow. Same time, same channel.
Yes, well, and actually, since you mentioned that, we will be setting up a new link for the webinar tomorrow. I think we have found through today's experience that we would prefer to go back to the Adobe Connect. So we will be sending out a new link to the event for tomorrow. And thanks to everyone for your patience as we worked through some of these issues, but we should be good to go for tomorrow, and look forward to having you hopefully join us again.
Great. Bye, everybody.
Thank you so much. And yes, thanks so much to Pam and Harold. And with that, we'll finish up for today.